Chiari syndrome is the obstruction of either the hepatic veins or the IVC. It was first discovered by George Budd and Hans Chiari. There's two types. It can be primary or secondary. The primary type is usually caused by a congenital membranous web that is in either the hepatic vein or IVC. So congenital meaning they're born with it. It's blocking the flow in the hepatic vein or IVC, and that's most common in Asia and South Africa. And the secondary version of Chiari syndrome is usually caused by an underlying condition that the patient has that makes them more susceptible to get blood clots. So maybe sickle cell disease, using birth control, liver cancer, pregnancy, inflammation of a vein, liver trauma, infections, growth of abnormal cells in the bone marrow, chronic inflammatory disease, and renal cell carcinoma. The signs and symptoms of Chiari are ascites, abdominal pain, hepatosplenomegaly. The liver will get enlarged because the blood, it can't get out, so it's backing up, so it'll enlarge. Jaundice, if the clot comes on maybe suddenly, the patient might go into shock. Palpable spleen, edema of the legs, and venous distension over the abdomen, flank, and back. And to diagnose Chiari, they'll do liver function tests, ultrasound, MRI, CT, and liver biopsy. To treat it, they'll give sodium or diuretic to help with the ascites or do a paracentesis. They'll give anticoagulants to break up the clot and thin the blood. Might do a shunt or a liver transplant for the patients who are mostly healthy otherwise. They'll maybe do a resection of the membranous web if they have the primary Chiari. They might do a stent placement and angioplasty. Angioplasty is when they insert a catheter with a deflated balloon at the vein, and then they'll inflate the balloon, and it'll open up the vein so the blood can flow more easily. They might do a transjugular intrahepatic portosystemic shunt, also known as TIPS. That's when they put a shunt in to bypass the liver. It'll connect the portal vein to the hepatic vein, and then the hepatic vein, of course, will go straight to the IVC. When you're looking at it on ultrasound, you might see that the patient has an enlarged caudate lobe, and that's a lot of times because of sparing of the caudate lobe hepatic veins when there's thrombosis in the hepatic vein, and also they'll have atrophy of the right lobe of the liver. You might have enlarged hepatic veins with thrombosis, but in chronic cases you won't see the hepatic veins at all. The flow in the IVC or hepatic veins change from phasic to absent, reversed, or turbulent, and there might be turbulent flow beyond the area of the stenosis. And when you're using the color Doppler to look at the vein, if there's slow flow, you might have partial obstruction of the vein, and if there's no flow at all, it could probably be total blockage of the vein. Okay, now I've got some pictures. This is a thrombus in the IVC. And then this is the distal IVC in transverse. These hepatic veins are completely blocked. That's why we can't see them. So that would be the chronic case because we can't see them at all. This is a hepatic vein in transverse. If you had the color flow on, you'd be able to see color all right here, but there's a clot. So there wouldn't be any flow right there where the clot is. This is a picture of the enlarged caudate lobe. It's compressing on the IVC. And this is another clot in the IVC right here.